So I was put to the task to do a complex valve-in-valve case. So my case, this is an 82-year-old female with a past medical history of hypertension, dyslipidemia, and diabetes. She had prior CABG or bypass surgery 20 years prior with a lima to an LED and a vein graft to an OM and OM1 and OM2. followed in 2000 with an AVR and mitral valve replacement with a 25 millimeter Magna pericardial valve in the mitral position. She has chronic stage 3 kidney disease and chronic pancreatitis and came to us with 3 months of shortness of breath. So here's her transthoracic echo. You can see normal ejection fraction on this view, thickened leaflets, severe bioprosthetic mitral stenosis, and you can see the antegrade mitral gradient is near a mean of 20 millimeters of mercury. The gradient across the mitral valve, the aortic valve was mildly elevated, and she had mild aortic valve dysfunction. So thickened leaflets on the transesophageal echo. On the right, you can see the difficulty in valve leaflet excursion with some central mitral regurgitation. So as we do our reconstructive CT and we think about valve-in-valve therapy, we're clearly concerned about LVOT obstruction. And you can envision if you put a mitral valve and you post the leaflets of this pericardial valve, that the risk for outflow obstruction is not going to be low in this patient. So if you create the neo LVOT using the 3Mencio software, as many of us do for this therapy, it was borderline around 180. And the question was this a safe therapy to actually proceed with valve-in-valve? Thinking of bailout options for her, the coronary angiogram revealed a patent lima to an LED and patent graft. Her native right system was normal. She had mid-LAD occlusion right after the first septal, and you can see there's a 99% stenosis at the ostium of that septal perforator. Some would say that this would be difficult for an alcohol septal ablation. Maybe it's actually quite easy if you can dissect that severe stenosis. You may actually knock out that septum and actually open up the LVOT. So based on our heart team approach, the STS score was about 10%. She was deemed inoperable for a second reoperative sternotomy, and we decided to proceed with a mitral valve-in-valve implantation. So we took the next steps. 8 French sheath was placed, as we've seen mitral valve-in-valves performed here on the case presentations. Pre-closed on the left, put a Langston catheter on the right to check gradients across the LVOT and aortic valve. Did our transeptal puncture, put the Agilis sheath, got the pigtail to run out the anterior wall of the left ventricle, placed our pre-shaped confida wire, which we like to use. Originally, when we were doing these, we were railing out the apex and putting even Lunderquist wires. Now with the confida wire, safer for the LV. Did our balloon septostomy with the 12 millimeter Mustang balloon and made sure that we were able to drive this across into the mitral prosthesis. So what we decided to do to assess for LVOT obstruction, they've done true flow balloons, which are perfusion balloons. I just show it on the right with the center lumen that's open in the aortic position as they position mitral valves to prevent LVOT obstruction. This is something that's been reported before. We actually use the perfusion balloon to post the leaflets of the pericardial valve to assess gradient. So we had the pigtail, Langston pigtail across the aortic valve, and as you can see on the right, the peak-to-peak gradient before the balloon inflation was about 40 and after it was 40. So based on this, with the 24 millimeter balloon, we thought that it was safe to proceed, that we wouldn't have to worry about LVOT obstruction. So during our inflation using TEE guidance, transgastric view, you can see that there's no color turbulence in the outflow, and we pulse wave through the outflow tract, and it looked good. Took the next step, proceeded with the antegrade approach, took a 26 millimeter S3 valve, cross, positioned it nicely, positioned it with the distal edge at the stent struts, and got a nice deployment with about 10 to 15% on the atrial side. And you can see on the echo after deployment that there really wasn't much turbulence across the outflow of the LV. And we pulsed it, spent some time looking at the system, and everything looked great. So we thought we were good. Took the system out, hemodynamics were great, the patient was doing well. And you can see, just looking at the turbulence and looking at the gradients post, that there was no change from when we had started the case. So 5 minutes after deployment of the S3 valve, she became hypotensive. Blood pressure dropped to 50. We quickly put an Impella CP in the left ventricle, decided to upsize the left system where we were. Well, actually, she already had the E sheath in. We put the Impella through it, gave her blood, fluids, and then we're trying to understand what had occurred. So our echocardiographer had identified that there was no LVOT obstruction. We already had the pigtail across previously, and then we started looking for effusion. We realized that there was no clear effusion on TEE, but there seemed to be some organized material around the heart. Decision was made because we couldn't see very well in transesophageal echo to do a dyna CT on the table, and we did see a pericardial effusion more towards the apex. On a transthoracic view, you can see nicely, it took us a little while to figure this out. I actually put a needle in the space before we were able to identify with the transthoracic probe, but you can see clearly to and fro flow that with the wire we lacerated the LV. On the right CFA, what we decided to do is pre-close. We upgraded to a 16 French cannula. The patient was actually stable with the Impella. Put her on pump via the right side via an A&V cannulas, and were able to remove the Impella catheter. Our surgeons did a left thoracotomy, exposed the LV, patched and directly sutured the left ventricle with pledgeted sutures, and were able to repair the LV successfully. On transthoracic, this is our post-transthoracic image. You could see limited pericardial effusion, but LV back to normal, and this is her being off pump. And I will say that 6 months post, she's actually asymptomatic and doing well, living independently. So some take-home points for us is that you can use the perfusion balloon as a way to assess neo-LVT obstruction. Clearly, LV laceration due to a preformed shaped guide wire is rare, but it can happen. So this has been reported with the Lunderquist wire across the LV, but now we've seen it. We had it happen to us using a Confida wire. But early detection for this is essential, and without it could be fatal. LV laceration in the setting of pericardic surgery could be a challenge to identify at least on transesophageal echo, and pre-procedural planning I think is key that allows you to really get full percutaneous access. And for this case, we really didn't have to do cut downs on the groin. So luckily, a challenging case. We were worried about LVOT obstruction. In the end, the patient did well from that regard, but suffered from an LV laceration, which we were able to bail out. So thank you very much.
Chad, I had a quick question. Not only the wire, I think the ballooning might have had some effect as well in pushing that wire across. Do you think that might have been
So, so the question was it the perfusion balloon? I mean, if you think about the timing when we were fully anticoagulated, she was stable the whole time. It was when we actually had taken out the entire system that she had crashed. So, I mean, if you look at the time delay from when we had inflated the balloon, kept it up for a couple minutes, the time was pretty long. So definitely a possibility, but not sure.
Did you consider percutaneous closure of the apical laceration at a time?
So it's a laceration, not a whole perforation. So, you saw nicely on the transthoracic image, and it took a little while to find it, but it was a tear in the ventricle.
Sometimes you get halfway in there, and then it becomes like a dissection. For your surgeon to find out where the actual tear is becomes problematic. And you ask, well, why the surgeons don't want to do the mitral valve? Why do this? Because it's really different. Doing a redo mitral with an aortic valve in place is really problematic. That aortic valve freezes it in place. It's very hard to do a redo mitral with an aortic valve in place. And sewing up a hole is a little bit easier. One thing I'll say about when you have a neo-LVOT that is borderline, you did that at 40% like everybody else did assistedly, but all the flows at 10% and 20%.
Agreed.
And so, if you go back, and we're starting to do it at all four phases, if it's big at 10 and 20, then you're going to be okay. And I would avoid putting a balloon in or the other problem with the perfusion balloon is that you don't have open cells. So if that works, it definitely works. That's basically a wall in LVOT. You can see it stuck this far beyond your valve, and yet it's not like your valve that S3 has its open cell. That's solid there.
To Dr. Reardon's point, is there a chance that you could fool yourself by inducing a gradient with that balloon so far across that you then end up doing things that you may not have had to do? that
Yeah,
they're
of
actually-
course. I mean, the goal for us was to end the balloon at the distal edge of the valve. And you're going to post a leaflet, so it's not technically the S3 valve, it's the leaflets of the pericardial valve. But agree, you don't want to drive it too far into the ventricle.
So the perfusion balloon obviously gives you a little bit of time to do your hemodynamic measurements and stuff like that. But I'm just trying to think that you're gonna
You drop flow, yeah.
into your LA, and how will that affect the physiology of the stroke volume going through your aorta?
So if you saw the gradients, the peak-to-peak gradients, there was a drop in pressures. So, clearly with the balloon inflated,
But some of your stroke volumes go down into the LA.
true.
I'm just trying to think about it. I just wonder if it may not be a true test of
True,
what's gonna
true.
happen, or your stroke volume. A lot of your stroke volume is actually going to the LA,
True.
but it gives you the time, obviously.
Great, thank you.